Good afternoon, everyone, and welcome back to the SRUK virtual conference. I'm Dr. Emma Blamont, Head of Research at SRUK, and I'll be your host for this afternoon's sessions. We have some great talks lined up for you. In our first talk this afternoon, we asked the audience, does doctor know best? Our invited speakers for this session, Dr. Alain Lescoat from Rennes University Hospital in France and Professor Francesco Galdo from University of Leeds, are looking at this very question in two exciting SRUK and World Scleroderma Foundation funded research projects. Alain and Francesco will highlight why patient-reported outcome measures are needed and speak about how they're involving patients to identify suitable patient-reported outcomes for scleroderma. As a reminder to the audience, please send your questions for the speakers in the Zoom Q&A during the talk. There'll be a Q&A session afterwards. Over to you, Alain and Francesco.
So hello, everyone. I don't know if you can hear me or see me. I hope so. So my name is Alain Lescoat. I am MD, PhD from Rennes University Hospital in Brittany in France. And I am part of the scleroderma program of that university hospital. I'm also a co-principal investigator with Professor Dinesh Khanna from the University of Michigan, USA, for the Crystal project that has received financial support from the World Scleroderma Foundation and SRUK. So the objective of my talk today is to give you some idea about what is an outcome measure, and especially in scleroderma. And I'll give you the example of the Crystal project. So I have no conflict of interest, and my talk today will be divided in 4 parts. The first part will be about important definitions to know, to understand how we work in a clinical trial. The other aspect of my talk is to give you the researcher and clinician perspective on outcome measure based on an analysis of the literature. Then I will talk about the patient's perspective based on our project, the Crystal project. And the last part of my talk will be about combined indices, and I'll give you some example and a specific example on what is a combined index. And then Professor Galdo will present his data about one of the specific combined index we have in scleroderma. So to begin with, I wanted to highlight that we have 2 words to mention scleroderma, which are systemic sclerosis and scleroderma. So, but this is the same disease, just only 2 words to talk about the same disease. But within systemic sclerosis, there are 2 major subsets. So the first one is the limited cutaneous systemic sclerosis that accounts for 70% of the patients, and that is characterized by distal cutaneous fibrosis, vascular manifestation, lower mortality rate, and high morbidity. The other subset is the diffuse cutaneous systemic sclerosis, and that is defined by widespread cutaneous fibrosis, early visceral involvement, fibrotic manifestations, inflammatory manifestations, and a higher mortality rate than in limited systemic sclerosis. So 2 subsets with some similarities, but also major differences that makes them difficult to be pulled together in some trials. So this is why we used to evaluate these 2 subsets in separate trials. So now, important concepts. I want to define with you the concept of outcome. So an outcome is a symptom or a clinical feature that will be used in clinical trial to assess the severity and the evolution of the disease. So there are many symptoms in scleroderma, so there are many outcomes in scleroderma, but they can't be organized together in what we call a domain. So a domain is a broad category that pull together different symptoms. For example, the pulmonary involvement domain or lung involvement domain will include the outcome shortness of breath, cough, etc. And you can do that for every manifestation of the disease and create different domains that will reflect the complexity of the disease and the different visceral manifestation or skin manifestation of the disease. So what is important and what is a major point is that the evolution of an outcome is used in clinical trials to assess the efficacy of a treatment or a procedure. Another aspect which is important is that when you choose the outcome, this will define the number of patients that need to be included in a clinical trial. So this is very important. Outcomes is the most important aspect in a clinical trial. So now a clinical outcome assessment or measure is defined as an assessment of a clinical outcome that can be made through report by a clinician, and in that case, we talk about a clinician reported outcome or ClinRO. It can be reported by a patient, and in that case, that's a patient reported outcome measure or PRO, or also called PROM. Or it could be reported by a non-clinician observer, and in that case, it's an observer-reported outcome or OPS-RO, but we don't use OPS-RO much in clinical trials. And the last kind of assessment is to assess an outcome through a performance-based assessment, which is asking the patient to perform a specific task and to evaluate his or her performance in doing that task. And that is what we call the performance outcome. So PRO or PROM are a measurement based on a report that comes directly from the patient about the status of a patient's health condition, but without amendment or interpretation of the patient's response by a clinician or anyone else. So that means that PROMs, or patient-reported outcome measure, directly reflect the way a patient feels and functions. And this is important because it means that we don't change the answer of the patient, but we evaluate directly the way he feels about his condition. So to give you precise examples about what is a domain outcome, an outcome measure, I will take the example of the pulmonary involvement or lung involvement domain, and we'll highlight the symptoms shortness of breath. That is our outcome. And you have here 4 different outcome measures to evaluate the concept of symptoms of shortness of breath. You can evaluate respiratory rate, and in that case, this is done by a clinician, so it is a clinician-reported outcome. You can ask the patient to fill a questionnaire like the St. George questionnaire, and in that case, this is a direct evaluation of the patient perspective on his condition, and this is a patient's reported outcome measure. You can ask an observer to provide an evaluation of the respiratory status. In that case, that's an observer reported outcome. And lastly, you can ask to evaluate, well, at least you can evaluate the distance done by a patient during the 6-minute walk test. In that case, that is a performance report, a performance outcome. So more specifically about the George questionnaire, here is an example of one question that is included in that questionnaire. So there are questions about what activities usually make you feel breathless these days. And then we ask the patient to tick in each box that applies to him or her during the past couple of days. For example, we'll ask, do you feel breathless these days while sitting or lying still? Is that true or false? Getting washed or dressed, etc. And then, for example, in a clinical trial, we can assess the proportion of patients that initially mention being breathless while sitting or lying still, and to highlight at the end of the study the efficacy of the treatment to reduce the number of patients reporting being breathless while sitting or lying still. So this is an example of a way we can use a patient-reported outcome to assess the disease and the impact of a treatment on the disease. So now when we come to the literature and the perspective of the clinician and researcher on which domains and outcomes have been mainly explored in, more specifically here, limited scleroderma. So this is part of our Crystal project to highlight what has been studied so far in scleroderma more frequently. So for that, we have selected 270 scientific articles, and we have analyzed them to see which domains were more explored than others. And what we can see is that from the clinician and researcher's perspective, what are the most studied domain are skin involvement, pulmonary involvement, quality of life, digital ulcers, and cardiac involvement. So this is what we have in the literature, meaning in the scientific articles. And when we more specifically focused on outcome measures, we can see that forced vital capacity, which is one of the PFT pulmonary function test parameter from the pulmonary involvement domain, is the most used outcome measure in the literature, especially to assess the efficacy of treatment. So this is a clinician reported outcome, and you can see that patient reported outcome are somehow neglected because they are not used a lot. And these highlight that we need to make efforts to include patient-reported outcome in clinical trials more frequently. So now, what is the patient's perspective on the most bothersome symptoms? So to answer that question, we have performed focus groups of patients with limited scleroderma to identify the most bothersome symptoms. And what the patients told us is that the most important domains from their perspective, based on their everyday life, are gastrointestinal domains, Raynaud's phenomenon, musculoskeletal involvement, fatigue, and pain. And interestingly, the Food and Drug Administration in the US have performed similar work and has demonstrated that the same domains were considered as having the most significant impact in the daily life of patients with scleroderma, highlighting that Raynaud's phenomenon, heartburn, and digestive symptoms were important, as well as fatigue. So very similar results than our results here. But these also demonstrate that from the patient perspective, these are the most important domains, and from the clinicians or researchers' perspective, these are the most studied domain, highlighting that, as you can see, they are very different. And that means that there are efforts to be done to focus more on what the patients considered as the most bothersome symptoms, especially in clinical trials. So another way to highlight which symptoms or domains are important is to try to create a map of the overall experience of patients in scleroderma. So one way is to list the different domains with symptoms, and what you can see is that there are some domains that are could be linked to scleroderma but are not very specific to scleroderma, like fatigue, pain, sleep disturbance, and this is what we would consider are as general domains. There are also limited systemic sclerosis specific domains that are considered bothersome from the patient perspective, and these include, for example, Raynaud's phenomenon, digital ulcer, etc. So this does not mean that these domains are more important than the general domains, but just that they are specific to the disease, and they are probably interplaying and interconnected. And all these symptoms will impact the everyday life of a patient with scleroderma in terms of functioning, emotional well-being, and this will mean that we will need specific management, adaptation, and coping to improve functioning, but also to avoid triggers, to avoid the occurrence of some major symptoms like Raynaud's phenomenon, for example. Another aspect of the patient's experience of scleroderma identified in our studies is the concept of uncertainty. People were mentioning that they were never sure if a new symptom was linked to the disease or not, because this is a complex disease. They were never sure when the symptoms would occur. And for some of the manifestation, like the cardiopulmonary manifestation, they also mentioned that even if they don't have these manifestations, they are afraid that they could occur at some point. And this is responsible for a high uncertainty, which is part of the disease. But when you look at these domains, one of the most important aspects is that they are interconnected together, they are combined together in the everyday life of a scleroderma patient. So this means that picking only one of them to design a clinical trials may not be enough, and that a good way of reflecting the overall disease would be, on the contrary, to combine different symptoms and evaluate them at the same time with the same tool. So this is the whole idea of a combined response index or a composite response index, is to include several domains at the same time so we could evaluate the disease as a whole, or the overall disease. So this is what has been done by Professor Kanna's team for diffuse scleroderma by the creation of the ACR-CRIS index, which is a combined response index for systemic sclerosis, and more specifically for diffuse scleroderma. And as you can see, this index will include different domains of the disease, like renal involvement, pulmonary involvement, cardiac involvement, but also skin involvement, pulmonary, overall evaluation, and quality of life. And interestingly, these composite index also include clinician-reported outcome, but also patient-reported outcome. So the perspective of the expert, the clinician, is included, as well as the perspective of the patient on his condition or her condition. And this is what we are doing now with the CRISTAL index. CRISTAL is for Combined Response Index for Scleroderma Trial assessing limited systemic sclerosis. So because the previous index was only for diffuse, now we're trying to create another index for limited scleroderma that will allow us to reflect the overall disease and not only one symptom of the disease. So what we have done is that we have evaluated the patient perspective and what are the most bothersome domains from the patient perspective. We have conducted the scoping literature review to list the different domains that exist in the literature. And now we are performing a Delphi exercise to select the important domains that we will need to include in that combined index. So as a conclusion, I wanted to highlight that combined or composite indices can include both clinician RO and patient-reported outcomes. So it's a way to include both the perspective of the patient and the expertise of the clinician. And now we are also including patients in every and each step of the selection process of outcome measures to be included in our future combined indices. So I want to thank again the Scleroderma and Raynaud's UK and the World Scleroderma Foundation for their financial support of this CRISTAL project. And want again to thank Scleroderma and SR UK for the invitation today. And I'm happy to answer your question at the Q&A session. Thank you very much.
Good afternoon, and I'm Professor Galdo from University of Leeds. Thank you, Emma, for the nice introduction, and thank you, Alain, Dr. Lescoat, for introducing what the concept of outcome measure and the work that has been done in limited scleroderma. I'm here, I've been asked to present the work that again has been funded by SI UK and the World Scleroderma Foundation on improving the way we measure diffuse scleroderma. You heard from Dr. Lescoat before that for diffuse scleroderma, we have this combined response index called ACR-CRIS. Now, this ACR-CRIS is a index that's been created by Dinesh Khanna and a group of researchers in the States that had the purpose to combine together different outcomes and help in interpreting how drugs work in diffuse scleroderma. This is important not only for doctors and for patients in clinical trial, but it's important also for health authorities when they need to judge how effective is a drug, how is really making a difference in scleroderma, and eventually decide if they want to reimburse this drug. So this combined response index in systemic sclerosis has several advantages. It combines multiple disease manifestation, or as you heard, outcomes, into a single outcome measures, and it is more sensitive than a single one. For instance, some patients with a drug may have only a partial response in their skin, but then their quality of life improves, and this index is able to capture both and to capture a response, even if there is only a partial response in skin or a higher response in lung. And it reflects how patients feel, function, and survive, as Alain has mentioned. Nevertheless, there are also some concerns or some not ideal features of this index. The first is that it measures the probability of response rather than how much a patient has responded. And so it might be difficult to be interpreted. And we don't know which scores reflect important difference on how patients feel, function, and survive. So it's altogether a probability of response. The other issue is that it groups together patients that worsen and patients that simply do not improve or stable. And so it cannot distinguish between patients that simply do not improve or patients that worsen. But as I mentioned, this index has several important features, including the fact that measures together outcomes that have been judged extremely relevant for diffuse scleroderma by both patients and doctors. And the first is the organ failure. Now, organ failure is defined for the purpose of the ACR-CRIS, either as lung failure, which is when the lungs lose dramatically function, and we measure this dramatically by 30% of a DRC or 20% of the forced vital capacity, or heart failure, and this is when the heart is not able to pump more than 30% of the blood that it receives, or when there is renal crisis, when the kidneys unfortunately stop working because of scleroderma. When either of these three manifestations happens, they're all considered as a organ failure or step 1 in the ACR-CRIS, and of course are a sign of no improvement. The other domain that is defined is the lung function, and lung function is measured by this index called forced vital capacity, which is a volume, a measure of the volume of the lungs. And for the purpose of improving the CRIS, we have defined improvement in FVC or worsening or in FVC in brackets that corresponds to a definition called minimally clinically important difference. Now, this MCID is a concept that is important when we describe outcome measures, because it is the threshold within that measure that has been judged as significant both by patients and by doctors. That means that is the threshold that patient can feel as an improvement or worsening, is the threshold that doctor will judge as a response to a treatment or a failure to a treatment, so escalate to some other treatment. So when either of these two are met, is called minimally clinically important difference. And for lung function, there are two thresholds for this MCID, either 5 or 10% as minimal or severe improvement, a severe worsening or a minimal or marked improvement. Now, the other index that is included in the ACR-CRIS and is important for scleroderma is this patient-reported outcome, and you heard about it already from Alain, but it's in this case is the HAQ-TI, which is a questionnaire is used a lot in many other rheumatological conditions, and many of you have probably done this questionnaire. And when there is a worsening or improvement of 0.2 points in this score, that is defined as significant both by doctors and by patients. And so we use this threshold to define worsening or improvement in HAQ-TI. And the other one is skin involvement. Of course, you heard then diffuse scleroderma is defined diffuse because of the amount of skin involvement, and that it goes proximal to elbows and knees, and is measured by this score called modified Rodnan skin score that in 17 sites score this thickness of the skin from 0 to 3. So max score of 51. Now, researchers have shown that a change in 5 points or 25% when the score is less than 20 are significant as far as improvement or worsening of skin score, both for patients and for doctors. And so the threshold used to define improvement or worsening at patient level for the Rodnan skin score is this 5 point or 25%. Now, which is the minimally clinical.
Okay.
So what have we done now? We have sorry for that. It was a recording. We have sent questions to patients and doctors around the world. We selected 200 people, 100 patients and 100 doctors. And we asked whether they could judge a patient, a example patient, according to worsening or improving in this course, and decide which patient, according to their opinion, was doing better or worse, so that we could get an idea of what was the opinion of doctors and patients in how important are these four domains: the organ failure, the FEC, the MLSS, and the HART-TI. So we asked questions like this one. This was an example question. If we have a patient that has a worsening of the FEC, which is at least 10%, and improvement of the MLSS at the same time, and you have another patient where the FEC is stable and the MLSS is stable, which patient do you think did better? And there were 15 to 18 questions that were asked to 200 people around the world, like this one, for improvement, and 15 to 20 questions, so a 15 to 20 pair of imaginary patients, so that we could get a feel from doctors and patients how important they were ranking. For instance, in this case, and you can ask this yourself, if you had a worsening of lung function by an improvement of the skin, or if neither of that either improved or worsened, how would you judge the best outcome? Which one of these two you think he did better, of these two patients did better? The one that had no worsening of skin and lung, or the one that had a worsening of the lung by improvement of the skin? And so the options were, I choose these patients, I choose this other patient, or they are equal. Now, we asked this question to 200 people, and 182 responded. Of these 182, 50 were excluded because either they started and never completed, or because they met some exclusion criteria, meaning they were hitting randomly in less than 1 second, either on the left or on the right. So 132 people completed the survey, of which 16 did not want to say whether they were doctors or patients. We invited 100 doctors and 100 patients. And so we have only 116 full demographics. And the 116 full demographics, we see that there were 70 clinicians and 46 patients. So it was not a 50-50 split, but there was a very good representation of patients. 40% of this survey were patients. And this is the time that it took. It took almost 1 year. The first wave here were doctors, and the second were patients. We invited them separately so that we could track the responses better. This was the only information we had. So their clinician of patients, their gender, the age range, and which continent they were responding to. And we had a good response from North America and Europe. Nobody answered our invite in South America, unfortunately, but we had four people from Asia, 1 from Africa, and 2 from Oceania. So it was more or less a global representation. Where were these results? So the results of these questionnaires, of these surveys, were analyzed by a statistical method called coin-joint analysis, where all the rankings or the choices are averaged according to how they agree with each other. And it's a bit of a complicated statistical method, but the important message here is that as far as worsening, doctors and patients agreed that the organ failure was the most important domain and should take 1/3 of the overall worsening scores. It was followed very closely by FEC. The third was the MLSS, and the fourth was the HART-TI. As far as improvement, the FEC was clearly the strongest domain, meaning that both doctors and patients felt that when there is an improvement in lung function, scleroderma surely improves, and improves more than there is just an improvement in skin or in the HART-TI questionnaire. So what are we doing with these ranks or these scores now? The reason why we did these surveys, as I told at the beginning, is because we wanted to overcome some of the limitation of the quiz, which is measuring a probability of response and not knowing really how much a patient has improved, rather than just if they had a probability of improvement or not. While we were conducting this survey, there was a second iteration of this quiz, this called revised quiz, that is partially addressing this concern. And so what we're doing now is that we are combining this score that we deducted from this international survey with the revised CRIS to define some specific brackets of improvement or worsening. This means that we will know by comparing the revised CRIS and the RCD here, you see an example analysis that we're doing on a clinical trial data set. We will know that if patients have a revised CRIS 20, means that they are improving at least 20% overall, or 30% or 40%, and we will know how important it is in the overall context of scleroderma outcome. Not only that, but we will be able to add a worsening domain to clinical trials, so that yes, we can measure response, but we can also capture the proportion of patients that are not responding to the drug, and the proportion of patients that are worsening, and how much they are worsening in their condition. So it is a difficult concept, and it is a science that takes a lot of time because it requires engagement of doctors and patients around the world. It requires a standardization of the definitions and of the methods, but is eventually the only tool we have to progress the clinical science in scleroderma and to get new drugs approved by the FDA, by the EMA, and here in UK by NICE and HRA. So it's time for question and answers, but before that, and to also inform and guide our question and answers, there is a short survey we would like to ask to the This is another.
Francesco, the audio's gone. Sorry.
No problem. So thank you to people that already answered the questions. It's 60% of you that have taken the survey. One of the thresholds that we like to have in this outcome measure science is 70 or 80%. Now, this is not a formal exercise, but it would be great if few more of you go back on this question and answer, even if you just say, I'm not sure. We like to have a bit more than 60%. There you go. Thank you. Somebody is picking up the invite, and few more. Very good. We'll give few more minutes. 63%. We really like to get to 65 or 70%. Is anybody else requiring a bit more time? "65 people already answered, 67, there we are. We'll leave it a few more minutes. In the meantime, I can read the questions loud. So the first one is, do you feel that the measures we have are adequate to determine how active or progressive is your scleroderma? The second question is, have you ever filled a patient questionnaire like Hack the Eye or others? And the third is, when you are at your doctors deciding how your condition is doing, do you think patient questionnaires should have more importance than clinician observed measure, the same or less? Now we are at the magic number of 70%. So we can close the survey, and if we can kindly share the result. Oh, there is one late comer just arrived. And that's very good, very good. So yes, please share the results. So there you go. Thank you, everybody, to everybody that has answered this question. 71 people did, which is great in only a few minutes. The first question that I thought it was important for a researcher like me and Alain and Dinesh that are working on this outcome measure is to grasp a audience, a UK audience, on what they think of how we're measuring scleroderma at this point. And the first question, as you have answered, was, do you feel that the measures we have are adequate to determine how active or progressive is scleroderma? Well, so the not sure is a very fair answer, because your patients are not supposed to judge, but some people were strong and say no. And a third of people said, I don't think the way my scleroderma is measured is appropriate. And 21 were a bit more satisfied. So there is a 50-50 split. 50 is not sure, and the other 50, the no wins a bit. Now, we wanted to also see how frequently you've been involved in clinical trials. And this is a very important question for me. If you see, have you ever filled a patient questionnaire? And this is because you are involved in an observational study or in a clinical trial, since this questionnaire are still not part of the standard of care, and 75% has never done it. That means that there is so much that we are missing about scleroderma when we don't hear how patients judge it. And on one side, this 75% of no is telling me that there is a very low participation in clinical trials in the UK. We can do more, we could do more studies, observational or interventional, because every patient should have the chance of being part of a study if they want to. And the second is that in routine standard of care, we don't have patient questionnaires, and perhaps we should think of including them. This is challenging for a healthcare system, but it's surely a point to take on our agenda. The third question was to have a feel of what do you think about how heavy, how important should be the results of a questionnaire. And the question was, when you are at your doctors deciding how your condition is doing, do you think patient questionnaires should have more importance than clinician observed measures, the same or less? And I am very glad to see that 70% of people almost say the same importance of other tests. So, which is more or less where the community is going. We want standard and standardized measures, but this should be only as important as what patients feel about their condition. Thank you very much for everybody that answered this question. I think this is a very valuable point for me, Alain, and the scientific community. And thank you to SI UK for facilitating this.
Well, thank you everyone thank you, Alain and Francesco, for a very interesting talk. And we'll now open up to the audience for the Q&A session. If you haven't already and you'd like to submit some questions, please send via Zoom. So I'm just having a look on the Zoom chat. So we have a question relating to, which I think relates to the relevance for these measures for all patients. So obviously scleroderma is a very diverse condition, and how are you going to ensure that the index serves all patients through the outcome measures included? Is there a risk that some patients might not be represented?
Yeah, sure. This is a very pertinent question, and the fear is very true. Whenever we look at a standard measure, we are looking at something that could be representative of most of the population, but this does not ever cover all the needs of a single patient. And this is something that we are very aware of, and that we cannot go around. What I mean is that in a clinical trial, you want to measure an aspect of disease, and you want to also have an idea of how the all over of disease is going. But for instance, if there is a drug that is very effective on lung function and does nothing on skin carcinosis, and in this question there is nothing about capturing carcinosis, but the drug is still effective on lung, yes, we want to be able to judge that drug is effective on lung. Well, and we need to remain aware that carcinosis is still not covered by the drug. So I think the correct way of addressing the impossibility of covering every single aspect of scleroderma in one single question is that to be aware of what is not covered and to have some specific studies for specific aspects of scleroderma.
Thank you, Francesco. So another question coming through is, how quickly can we expect to see the results of this project translated to noticeable differences for scleroderma patients?
Alain, you go first.
Okay, so what we've done so far, it took us 1 year to do it, is we have identified which symptoms or outcome are the most bothersome from the patient perspective and what has been done in the literature so far. So now we are pulling together a Delphi exercise to select the outcome. So it means that it's going to take 1 more year, and then we will need to include in clinical trials these indices and to see which one is the most relevant one from the patient perspective, but also in real life situations. So it's still a couple of years before we'll be able to use this index, but the sooner we start, the sooner it will be available. So yeah.
Thank you, Alain. And that the fact that it's even on the research agenda, a combined index for limited scleroderma, is great, and it's all the credit to WSF and to SRUK that have decided to fund this initiative, because there was none. But yes, it will take 2 or 3 years. Whereas for the diffuse, we are a bit ahead of time because more trials have been run in diffuse scleroderma, and the ACR-CRIS was already an index that was considered a potential outcome. So this revised CRIS and this RCID together are already included today in 2 clinical trials that have been designed to launch in the first months of 2022. So that means that when the trial stops, so they've been used, they will be used in the next few months. And when the trials will finish, we can use these indexes already to judge how the drug was effective. And so for the revised CRIS is already here, and the RCID and revised CRIS combined, it will be next year that we will know how well they work together for a clinical trial.
Okay, well, I think that's, we're coming to the end of the time for this session. So if there are no more questions, let me just check. No, I think we have no more questions coming through. I'd like to thank both our speakers, Dr. Alain Lescoat, Professor Francesco Galdo, for presenting in this session, and thank the audience for their attention and questions.